Welcome to the Deep Dive, your express route to mastering key topics for the MSRA.
Glad to be here.
Today, we're diving deep into splenomegaly, what it is, why you absolutely need to know about it for your revision.
Exactly. Splenomegaly sounds complex, but really it's just an enlarged spleen.
Simple enough, but the spleen itself isn't so simple, is it? Tucked away up there.
Not at all.
Oh.
It's quite the powerhouse, actually. In your upper left abdomen, constantly filtering blood, major player in the immune response.
And recycling old blood cells, you mentioned?
Yeah, the body's recycling center does a lot. Produces immune cells, antibodies crucial for what we call humoral immunity.
Okay, so antibodies, immune cells like B and T cells, plasma cells.
Right. They're made there. Plus, it clears out old red blood cells, and it acts like a reservoir for white cells and platelets, ready when needed.
A reservoir, I like that. And a key point for exams, you usually can't feel it normally?
That's right. If you can actually palpate it, feel it below the ribs, it's generally at least double its normal size.
Wow, double. That enlargement must have consequences. You hear about hypersplenism.
Definitely. That's when the enlarged spleen gets, well, overactive.
Overactive, like too good at its job.
Kind of, yeah. It starts removing too many blood cells, red cells, white cells, platelets. Leads to pancytopenia.
Pancytopenia, low everything.
Pretty much. So you get anemia, risk of infection goes up because of low white cells, and bleeding issues from low platelets.
But the bone marrow is still working.
Usually, yes. You look at bone marrow and it's normal or even working overtime, hyperplastic. So the problem isn't production, it's the spleen destroying or just pooling the cells.
Okay. And there's a really acute version in kids with sickle cell.
Yes, splenic sequestration crisis. It mainly happens in young children. The spleen suddenly traps a huge amount of red blood cells.
Sounds dangerous.
It is. It can cause a massive drop in blood volume, leading to shock. It's a real emergency, and sometimes requires splenectomy, removing the spleen.
Right, that definitely highlights why an enlarged spleen is such an important clinical sign. So our mission today is clear. Give you a really solid, memorable overview of splenomegaly for the MSRA.
Covering all the key points you need.
Let's start with the absolute basics then. The definition again?
Splenomegaly. Simply, enlargement of the spleen beyond its normal size. Remember, its location, upper left abdomen.
And crucially, it's a sign, not the disease itself.
Precisely. It's pointing towards an underlying problem.
Like a check engine light for the body. Okay, any tips for remembering the spleen's role and why enlargement matters?
Let's try this. Think of the spleen as the body's recycling and defense depot.
Recycling and defense depot, okay.
Yeah, it recycles old cells, defends against germs. Splenomegaly means the depot is either working overtime, it's being invaded, or maybe there's a blockage, something's up.
That works. That definitely sticks.
Good.
So what are the things that cause this depot to get overloaded or blocked? The causes, the etiology? Sounds like a long list.
It is quite broad, so breaking it down helps. First up, infections. Lots of them.
Like what?
Bacterial ones like TB, brucellosis, viral stuff like glandular fever, that's EBV, hepatitis, even endocarditis. And parasitic infections too, schistosomiasis, malaria, visceral leishmaniasis. These all make the spleen work harder.
Makes sense. Fighting infection, the spleen's on the front line. What's the next big category?
Liver diseases, big connection there. Think cirrhosis, portal hypertension.
Ah, the back pressure thing.
Exactly. Increased pressure in the portal vein system backs up into the spleen. Also, Budd-Chiari syndrome, blocked liver veins. Even just general liver failure can cause congestive splenomegaly.
So blockages and back pressure. Got it. What about problems with the blood itself?
That's another major group, blood disorders. Hemolytic anemias, for instance.
Like sickle cell, thalassemia.
Right. The spleen works overtime, clearing out abnormal red cells. Then you've got leukemias, both acute and chronic.
Cancer cells infiltrating.
Yes. Also things like polycythemia rubra vera, essential thrombocythemia where you're making too many cells, myelofibrosis, where the marrow gets scarred, and lymphomas, Hodgkin's and non-Hodgkin's.
Wow, okay. That's a lot of hematology links. What else?
Autoimmune and connective tissue disorders.
Yeah.
Things like SLE, lupus, and Felty syndrome and rheumatoid arthritis. General inflammation can affect the spleen.
Right, systemic inflammation, and sometimes things actually build up in the spleen.
Yeah, that falls under infiltrative diseases and tumors, amyloidosis, where protein builds up, histiocytosis X, a rare immune cell disorder, And actual tumors in the spleen, hemangiomas, metastases from other cancers,
Cysts, like hydated cysts.
hydated dermoid cysts, yeah.
Yeah.
Even splenic abscesses, collections of pus.
Okay. Are there metabolic causes too?
Yes, metabolic disorders,
Yeah.
Coucher's disease, Niemann-Pick disease.
Hmm.
These are inherited conditions where fatty stuff accumulates in organs, including the spleen.
We're covering a lot of ground. Any miscellaneous causes?
We lump a few under other causes. Trauma to the spleen is one. Sometimes pancreatic issues like cancer or a pseudocyst can affect it. And interestingly, about 5% of the time.
You just don't find a cause.
Exactly. We call that idiopathic splenomegaly.
And some of these can make the spleen absolutely massive, right?
Correct. For massive splenomegaly,
Sorry.
think CML, chronic myeloid leukemia, myelofibrosis, that hyperreactive malarial splenomegaly, leishmaniasis, Gaucher's, and sometimes that idiopathic tropical splenomegaly.
Okay, quite the list. Now, you mentioned something crucial earlier about sickle cell. The spleen doesn't always stay big.
Yes, very important point. In sickle cell disease, especially later on, the spleen can actually shrink, become atrophied.
Why is that?
Repeated infarcts. Little areas of tissue die off due to lack of blood supply caused by the sickling. So while it's often enlarged early on, it can end up small and non-functional. Don't get caught out by that.
Good tip. Right, with all these causes, how on earth do we remember them for the exam? You mentioned a mnemonic.
Always helpful. Try this one.
I lick but.
But a tiny inky mass.
Okay. I lick but a tiny inky mass. Let's break it down.
I for infections. L for liver diseases. B for blood disorders. A for autoimmune. K for tumors. And cyst abscesses. I again for infiltrative diseases. M for metabolic. O for other. Another I for idiopathic. And finally, mass for the massive causes.
I lick but a tiny inky mass. It's memorable. I'll give you that. Might just stick. Okay, moving on. Risk factors. Who is more likely to get splenomegaly?
Well, it really boils down to the risk factors for the underlying conditions we just went through.
So it's not splenomegaly itself that has risk factors, but the cause.
Exactly. So if you have chronic liver disease or a history of malaria or, say, a family history of leukemia, your risk related to that condition is higher, which in turn means your risk of splenomegaly is higher.
Depends entirely on the specific cause then. Makes sense. Let's talk pathophysiology. How does the spleen actually enlarge? What are the mechanisms?
It varies, again, depending on the cause, but there are common pathways. One is just increased workload. Like in hemolytic anemia, the spleen's working harder, so it gets bigger, hypertrophies.
Makes sense, like a muscle.
Sort of, yeah. Another is congestion. That's the liver disease. Portal hypertension mechanism, blood backs up, swells the spleen.
Okay.
Then there's infiltration. Abnormal cells like in leukemia or lymphoma or substances like amyloid physically build up inside the spleen.
Invaders, basically.
Pretty much. And finally, increased immune activity. Big response to infection or autoimmune disease makes the immune cells multiply within the spleen, enlarging it. Often it's a mix of these things.
Increased work, congestion, infiltration, immune response. Good framework. Now, differentials. You feel a mass in that upper left quadrant. What else could it be besides the spleen?
Good question. Number one is probably liver enlargement, hepatomegaly spilling over to the left.
Okay.
Could be other abdominal tumors, maybe from the kidney, stomach, pancreas, colon.
Right.
Enlarged abdominal lymph nodes, lymphadenopathy can sometimes feel like a spleen.
Yeah.
And you always have to consider other reasons for the patient's symptoms like anemia that might not be spleen-related at all.
So, careful examination and imaging are key to figuring it out.
Absolutely.
What about how common this is? Epidemiology in the UK.
It's tricky to pin down exact numbers for splenomegaly itself because it's a sign, not a diagnosis. Prevalence really depends on the rates of the underlying causes.
But we have some idea of the common culprits in the UK.
Yes. Studies suggest that hematological diseases, blood disorders, leukemias, lymphomas are the most common underlying cause, maybe around 39%.
Nearly 40%. Okay.
Then, hepatic diseases, liver problems, maybe about 18%. Infections account for perhaps 10%. The rest is a mix of other things. It gives you a feel for where to focus your thinking initially.
That's really useful context. Okay, clinical features. How does a patient with splenomegaly actually present? What do they tell you?
Often they might not notice anything, especially if the enlargement is mild. It might be found incidentally.
But if they do have symptoms,
A classic one is a feeling of fullness or discomfort in the left upper abdomen, sometimes even pain. Also, early satiety is common.
feeling full quickly because it's pressing on the stomach.
Exactly. They might also have fatigue, Maybe symptoms of anemia, like shortness of breath, if hypersplenism is kicking in. More frequent infections if white cells are low. And of course, symptoms of whatever the underlying cause is, fever, jaundice, weight loss.
And on examination, the key finding is...
A palpable mass in that left upper quadrant.
Okay, and what are the specific things you're looking for when you examine that mass?
Key features. It should move downwards with inspiration, towards the right iliac fossa. You generally can't get your fingers above it because it's under the ribs.
Right.
You might feel a characteristic notch on its edge, and it's usually dull to percussion.
Got it. Movement with breathing, can't get above it, maybe a notch, dullness. What else should you look for?
Definitely check for a lymphadenopathy elsewhere, and signs of liver disease, jaundice, ascites, spider naivety, palm or erythema. Puts the spleen finding in context.
Okay, quick recap question for everyone listening. Patient has LUQ fullness, early satiety. What exam finding really points to splenomegaly?
That would be the palpable mass that moves downwards with breathing, extends towards the right iliac fossa, and you can't feel its upper edge.
Perfect. So you suspect it clinically. What investigations do you order?
Well, start with the basics. The physical exam itself is crucial. Then baseline blood test, definitely a full blood count, FBC, and liver function tests, LFTs.
FBC for cell counts, LFTs for liver involvement. Makes sense. Then imaging.
Ultrasound is usually the first port of call. It's non-invasive, easily available, confirms enlargement, and can give clues about the cause.
And if ultrasound isn't clear or you need more detail?
CT scan is often next. Gives great anatomical detail. MRI can sometimes be helpful too.
What about actually taking a piece of the spleen, biopsy?
Splenic biopsy is done sometimes, but carries risks, like bleeding. It's usually reserved for specific situations, like suspected lymphoma or infiltrative disease, often guided by imaging.
Okay. And further tests depend on what you suspect.
Absolutely. Could be bone marrow biopsy, liver biopsy, lymph node biopsy, specific infection tests, autoimmune markers, maybe even genetic testing, depending on the clinical picture.
A tailored approach. Now, management in the UK. What's the strategy?
The absolute cornerstone is treat the underlying cause. Whatever it is, infection, liver disease, blood disorder, autoimmune condition, you target that primary problem.
And does that usually shrink the spleen?
Often, yes. If you successfully treat the cause, the spleen may return to normal size.
Are there times when you'd actually remove the spleen? Splenectomy?
Yes. It's considered in certain situations, for example, in hereditary spherocytosis, where red cells are destroyed excessively, or sometimes as part of staging or treating Hodgkin's lymphoma. But it's not a first-line treatment for just enlargement itself.
And what else is important in management?
Regular monitoring of the spleen size and blood counts is key. And crucially, for anyone with poor spleen function, either post-splenectomy or due to disease like sickle cell prophylactic vaccinations, are vital.
Vaccinations against specific bugs.
Yes, particularly encapsulated bacteria like pneumococcus, meningococcus, and Haemophilus influenza type B, because the spleen is so important in fighting those off. Also, annual flu jabs.
Right. Protecting against infection is paramount if the spleen isn't working properly. What about the long-term outlook? Prognosis.
It really varies enormously. It all hinges on the underlying cause and how effectively it can be treated.
So some causes have a good prognosis.
Yes, if the underlying issue is treatable, like many infections or some hematological conditions caught early, the spleen can shrink, symptoms improve, and the prognosis can be excellent.
But not always.
No. If the cause is something like advanced cancer or irreversible liver disease, then unfortunately the prognosis associated with that condition is often poor, and the splenomegaly is just part of that picture. Regular follow-up is always needed.
A realistic perspective. Okay, lastly, complications. What can go wrong if splenomegaly isn't managed or the underlying cause persists?
Well, we've touched on hypersplenism, the low blood counts causing anemia, infection risk, bleeding.
Yeah.
That's a major one. If it's linked to portal hypertension, you worry about developing varices in the esophagus or stomach, which can bleed catastrophically.
Okay.
And just the ongoing underlying disease process can lead to progressive organ damage and other complications related to that specific illness. It can become life-threatening if not addressed.
So, definitely not something to ignore. Okay, let's wrap up this deep dive. Key takeaway.
Splenomegaly is a really important clinical sign. It's a flag telling you something else is going on systemically. Understanding the causes, features, how to investigate, and the potential complications is vital for your MSRA prep and clinical practice.
Think of it as that detective, like you said, uncovering hidden issues. Splenomegaly is the signal.
Exactly. It's the spleen saying, hey, look over here.
Okay, here's a final thought for you to ponder. Given that huge list of causes, if a patient walks in with splenomegaly, what are the absolute first, most critical investigations you'd want, and why? Something to mull over.
Good one. Keep thinking clinically.
And for more top-notch MSRA revision resources, including practice questions on splenomegaly and everything else, make sure you head over to passthemsra.com.
Plus, don't forget freemsra.com. Loads of great free learning materials there to help you ace the exam.